few things that have changed over the years with these forums, the size of the audience, the venue. One thing stays the same. We wouldn't think of having one of these forums without inviting Professor Cole, who's, I think, one of the few, if not the only, rehabilitation physician who's so passionate about brain tumour patients and their outcomes. When he sort of, some decades ago, he realised there was quite a bit of information about stroke rehabilitation and almost nothing in the literature about rehabilitation for brain tumour patients, and he changed that, and he's been very involved in so much advocacy and so much education for rehabilitation physicians around Australia. So please welcome Professor Andrew Cole.
I'd just like to say that one thing has changed, and that is the colour of my hair. Okay. Oh, that's interesting. Good. We've got a colour change. All right. Excellent. That's coming up. Good. So I'm talking about adjusting after the diagnosis and the role of rehabilitation, and amongst other things, the debate about driving. That all sounded a bit complicated, so I've called it Getting On With Life, How Rehabilitation May Help After Brain Tumour Treatment. The question is, what if problems are there after treatment for a brain tumour, as they very often are? Some examples, a stroke-like picture, depending on the size of the tumour and what operations have been done. And I was greatly encouraged to hear the surgeon talking about his considerations about what they do and what they don't do. But people do come out after surgery and treatment with a weak arm or a weak leg or speech problems, or they can't do things in their personal life, difficulty getting on with life that looks awfully like a stroke. And the thumbnail is that attacking those people with a rehab program in the same way that you'd approach a stroke patient actually does produce good results. But there are less obvious problems as well, problems with thinking, problems with logic, problems with reasoning, problems with mood, and then the other things that everyone gets on a Friday afternoon after a busy week, problems with feeling very tired, washed out, or just brain fog. But those are real issues with brain tumours, as we know. And I think the important thing to realise is that you can't treat something you don't know is there. In medicine, we teach our students on the way through, and it's all self-interest because one day those students are going to grow up and look after us. We teach them that there is no treatment without diagnosis. If you don't know what's going on, if you haven't looked into what's going on, you can't treat it. So asking for problems to be assessed by a rehab specialist and a rehab therapy team, by which I mean the allied health staff and the nursing staff that are with the rehab person, very important. The rehab specialist will come and assess you in a hospital or a clinic. They'll do a full medical history and a physical examination, and they'll often be looking for things that may have been missed in the general background that are not specific to the brain tumour, but trying to understand the extent of all the problems in the person's context, because everybody is a unique, I was going to say problem, but that's not quite right. Everybody's a unique challenge. Okay, everybody is constructed differently, their life experience is different, their family's different, their resources are different. We've heard at great length today about how their tumour biology is different, their treatment's different, and it's a unique issue. So, in that team, the physios are obviously particularly looking at muscle and mobility, walking control, balance, and endurance problems. So a lot of people, they'll come out after treatment and they can actually walk quite well for 50 feet. But you ask them to walk 300 yards and they're really not in the game. Or you ask them to go up a flight of stairs and after a couple of stairs they're in trouble. So endurance is often a real issue. Occupational therapists are looking at problems with daily life. The most basic ones, starting with washing and showering and dressing, whether you can stand up or you need to sit down on a plastic chair for showering, use the hose, have a good old splosh, and then they move on to feeding and cooking, and then the outside tasks of shopping, going to Woolies, working out what you want on the shelves, and your leisure things. Very, very important and often neglected, because when people have serious illness, there's kind of an assumption that the family will take over and do those things that are a bit complicated outside of the house. Whereas mostly what we value as people when we're patients, and having had a patient experience once or twice myself already, what we value is the ability to do things for ourselves. Yep, independence. Okay, I did it my way. I've run out of the number of times I've been to services where that's been the song that people have sung. Very important in Australia, even if it's an American song. Speech therapists assessing swallowing problems, communication issues, and the need to assess a person's ability to understand speech as well as to express speech, because often the understanding may be affected, and that's a bit less obvious until the person actually starts to talk more and more. And finally, social worker, and I'd put psychology in this bit, dealing with family care and network issues at home, work issues with finances, accommodation, community problems, and I'm sorry, there's at least one four-letter word in my talk, and the four-letter word is NDIS. And I listened to Bill Shorten on the radio this morning when I was driving to where I was going last, and he says he goes to sleep thinking about it at night, and he wakes up in the morning, and I thought, you poor man, you've got a very limited life. But it is a real issue. For people who are in the working age group, there's a lot of support there available within the NDIS, but it's very limited. It's very limited in the way that they target it, and you have to show that you've got a stable disease before they'll think about it. So the rehab team will discuss everyone's goals for what they want improved. They'll provide rehab therapy at the best time and in the right place, whether that's in hospital or whether it's coming back to a therapy or a unit, or whether it's being provided in the home. And they'll review that in conjunction with you and your family and the team members so that everyone's on the same page. Practical example, getting around in the community. Everybody wants to get out of hospital. The only people I know who want to stay in hospital are those that have mental health issues, usually speaking. And everybody wants to get out of hospital. I mean, look, the environment it's lovely with the people, but if you've ever tried to sleep in hospital, it's awful. It's like trying to sleep in Central Railway Station or Pitt Street, you know, when they're bringing the construction trucks in at 5 o'clock in the morning. And there's all these machines that go beep, and there's nurses that run around and ask you in a loud voice all sorts of interesting questions about your bodily functions that nobody's asked you about since the age of 3. And it's difficult. You want to get out. But to get out and to be able to get around and do things, you have to be able to move safely from wherever you are to the vehicle that you want to go in as a passenger to start with. So that presupposes the ability to move safely, to be able to be transported safely for somebody to push you if they're pushing you in a wheelchair, getting into a vehicle. SUVs are much better to get into than anything else, which is why I suspect they're the most popular cars in Australia. Even if you've got problems with your hips and your knees, all you have to do to get into an SUV is to back up with the door open and the seat in frontly, and gently lower your bum onto the seat because it's about the right height. Somebody can swing your legs over it and off you go. Properly belted in. Must be properly belted in. You don't want to add another brain injury that's treatable on top of what's going on with your tumour. And if feeling sick with sitting in a car is an issue, there's two possibilities. Simplistically, it's a bit like, is the tumour positive one way or negative the other? With feeling sick in a car sitting up, is it just a simple thing like you're not used to sitting up and your blood pressure's dropping when you sit up? And that's easily measured. You can review the medications, you can check what's going on, and if it's really difficult, you can put a person on a table that's flat to start with and tilts up, put them up to 30 degrees, watch their blood pressure, put them back flat, and retrain the blood pressure reflexes over a week or so. Or is it related to 3D movement of the head in space? Good old motion sickness, okay? The kind you get on a Viking cruise in a storm in the Mediterranean. First thing with 3D head movement in space, exclude simple problems. Wax in the ear. Very simple problem. And if you've been in hospital for a couple of weeks and you haven't had your normal shower regime, you haven't been doing this with your ears normally under the shower for a couple of weeks, there's a fair chance you're going to get hard wax in your ears. Worth having a look at. Simple thing to fix. Or even something simple like a blocked middle ear. Sinus issues or something like that. But if there's other signs that suggest it might be a brain issue, if, for example, when the person sits up and they get the dizzy sensation, you see their eyes flicking to one side or something like that. There are medications that you can try that will improve and dampen down that situation. But in general, anyway, if you have motion sickness in a car, and unfortunately I have two children that experienced this when they were small, and we didn't have a bench seat, so we put one in the back seat till the noises started, then we'd swap the front and the back seats around and drive another 10 kilometres. Sit in the front seat of the car and fix your eyes on the horizon. Because in fixing your eyes on the horizon, your vision and your ears are aligned in a way that they're not when you're looking here, there and everywhere in Sydney traffic. Fix your eyes on the horizon and stay right ahead. But what if you want to drive again? This is what we get questions about all the time. It's a complex task. It's like playing the pipe organ. You've got to do things with your hands and your feet while you're not looking at your hands and your feet. You're looking at the music in the case of the pipe organ, and you're looking at the road in front of you. And you're thinking about, where am I keeping my place on the road? What's my speed? What's my position? And if you've got issues following treatment for a brain tumour with cognitive linkage of parts of your brain to do with motion and awareness and vision, you can have problems and not realise it. Being aware of other users and keep safe distances and avoid physical contact between vehicles, which is a cultural matter, of course. If you go to Hong Kong, it's very different than it is in Sydney. And all that needs eyes and ears and cognition and muscular control and good thinking and judgment. But it's a social issue as well. Okay, it's a social issue. Travelling by public transport, even in a city like Sydney that's pretty well connected, at least in the inner 20 kilometres of it, not so good out in the far west and the southwest, it's important for our social identity to be able to go where I want, when I want, how I want, isn't it? It's an important social rite of passage, especially, fellas, for us. It's a very important thing to have gotten our licence when we were 16 or 17 or whatever, to be able to take our current best beloved to whichever drive-in and do whatever, running around the place and doing all those sorts of things. However, there are legal issues with driving a car because driving is a privilege. It is not a universal human right, thankfully. It is a privilege. It's regulated by a triangle of responsibility. The person driving the car, the healthcare worker looking after that person, and the driver licensing authority. So the individual driver, we should be asking ourselves, do I need to drive in any situation? Because if we crash a car, we're primarily responsible, aren't we? We must acknowledge, at law, we must acknowledge if we have medical problems. We must have insight to realise the issues from those. And if we have chronic medical problems, we have to report these to the doctor or driver licensing authorities like the RMS. The healthcare worker, that is we, ask, do I think this person's safe to drive a car? So we need to consider the effect of the illness, whatever it is, on daily life, and there are big ethical dimensions here, especially if you've known the person for a long time and you're the person that's got to say to them, actually, I don't think you're safe. Now we see that as a major issue in another part of my practice dealing with elderly people, particularly with memory problems, but assessing the effects of disease on the function, and then we have to advise impartially if a person's safe or not to drive, and we have to report to the driver licensing authority. There's an allegedly intelligent life form that lives on the other side of the Blue Mountains somewhere, I think at Orange, and you ring them up and you hear crackles on the line, you know you're getting through to somewhere near Mount Canobolas, and they ask, is it safe or legal for this person to drive? They put together the individual medical information and they put together the recommendation from the healthcare worker, and they apply the standards, and it's a simple matrix. And is the person safe? Or are they safe to drive with conditions, or do they not drive at all? I have a condition on my licence which is now obsolete, which says I have to drive with glasses. It's actually not now necessary since I had my cataracts operate, because this eye is set for reading, this eye is set for distance, and I can go down the expressway and look at the signs like that and look at the speedo like that. But the great thing is that I can have both eyes open at once and it suppresses whichever image it doesn't want. I said to my ophthalmologist, what happens if it doesn't suppress? He said, you are getting dementia in that case. So it hasn't happened yet. But legal sanctions apply if we don't comply with the decision of the driver licensing authority to drive, or only to drive with limitations. they will come after you if you do the wrong thing. So thinking about driving assessments, psychologically, physically, we're not the same person we were when we were 17, thank goodness. Functionally, has a person got weakness in one hand, weakness in one foot, something like that? Does the vehicle need to be modified? And do they understand the road law, especially with cognitive changes, as the road law applies today? Because the road laws today are not the same in all details as the road laws that applied 5 years ago, and they're certainly not the same as the road laws that applied when I was a lad learning to drive a car some decades ago. So the practical steps are a full medical driving history, examine clear documentation of the main conditions, and make a decision, and they're all kind of medical steps. Inform the result and advise the person, and I always do it with family members present. Always. I mean, I do most things with my care with family members present if I can, because rehab is a very family care environment-oriented discipline. But if two people are hearing information, I mean, you know, whenever anybody looks at information, one person hears something, another person hears something, you've got a third person in the room, they'll hear something different again. So it's a great opportunity for people to cross-check, but it also restricts the possibility for people to actually not kind of report honestly what's going on. Then you report to the DLA and you follow things up because, as we've heard, particularly with brain tumours, things may change over time. So what may have looked quite safe in October last year, if there's a tumour recurrence and you're not following the person up regularly, it may no longer be safe to drive. Specific problems, if you had a blackout for any reason, these are not just brain tumour problems, if you've had a blackout for any reason, you're not allowed to drive for 6 months unless a specific cause is found and treated. If you have a first epileptic fit, even if it's successfully treated, usually they say don't drive within 6 months unless you're an epileptologist who's certified you to drive sooner than that. And if you have neurodeficits, should not be driving for 6 months after surgery. And if the deficit involves anything to do with vision, so there's no vision in half the world or there's neglect in half the world, that person should never drive again for obvious reasons. If you can't see half the world, how can you drive? So visual acuity, you've got to be 6 on 12 or better. You're not allowed to have more than 20 degrees of central loss, and you must have at least 110 degrees of vision in your horizontal field. With the brain tumour itself, as we discussed earlier, thinking and logic may be impaired without realising it. And if either you, as the brain tumour person, or your family are worried, get a rehabilitation opinion. Get a psychology check done. And generally speaking, after treatment for a malignant brain tumour, it is not appropriate to get a commercial driver's licence and drive a 20-tonne truck or a bus or anything like that again, because those vehicles are obviously very large, can do a lot of damage if they, much more than a start motor car or a little SUV or something like that. So getting back to driving, I've talked about the assessment. I've talked about the cognition and judgment. If there's worried, then people will ask for an off-road test, specifically look at road rules and car placement on the road, and there are computer programs that do that, and then possibly an on-road testing with an instructor plus an occupational therapist. Those last two items are not covered by Medicare, and they do cost somewhere up to $1,500, which seems like an awful sum of money, except that if there's anybody in this room that's recently had a teenager that's been learning to drive, and you add up the cost in your time of the 100 hours or whatever it is in the logbook, and the 10 hours before they're even slightly safe that you send them off to a driving school, so they're not going to drive your car into the back of somebody else's, they'll drive the driving school car into the back of somebody else's to start with. It actually isn't that different to the real cost of getting a teenager on the road now, if you think about it in those terms. What about travelling longer distances? Well, on the surface, there's bus or train. It's all very well to get into a wheelchair and be pushed to a bus station or a train station, but you actually need to think, can I get through and how am I going to get through the check-in, the boarding process? Can I get in and out of the, I know about and get in and out of the car, but can I get in and out of the vehicle and a seat? And one of the difficulties with long distance buses in particular is there's usually 3 or 4 or 5 quite steep steps to get up to the next level. And that's why if you can still get a train, but unfortunately they've chopped them to so many places, if you can still get a train for a long distance journey on the surface for more than a couple of hours, it's actually preferable, because the platform's level, you walk into the train on the level. There are places where disabled wheelchairs and so forth can be locked into a train, and the toilets are much more easily accessible on a train. Okay, you can be crossing the Hawkesbury River watching the view out the window as you're doing your business on the toilet, which you can't do on a bus. You've got to stop to get off on a bus, or you've got to stop and crouch in that little tiny thing under the stairs. I don't know how people do anything in those spaces apart from store empty drink cans, but anyway. But in any sort of longer distance travelling, the question is there a helper available? What about air travel? Well, it's more complex, it's more expensive, but one of the fascinating things about having a practice with people who come from many different places and having moved from the north side of the harbour to be banished to the far southwest, where we have 50 different communities surrounding us at Brayside Hospital. A lot of people ask about, can I travel, doctor? And can I go and see whomever? And can I go and see my relatives in China, brackets, take some herbal medicine while I'm there? It is more complex. So from the front door of the airport till actually boarding the aircraft, there's often a distance of almost a kilometre, if you think about it. And even just doing it in a wheelchair, it's pretty exhausting because the screening process and all that sort of thing. So if a person has any degree of disability on a long flight, I say go with a companion. Go with a companion, because you don't know when you might need more hands-on help than is ordinarily what you need, if that makes sense. Economy seats are cramped, okay? 75 centimetres between the seats. For me, at 6'4", means that I sit in the seat with my knees jammed up solid on the back of the seat in front. Heaven help the person in front of me who wants to recline their seat, because they just can't. There's this block of wood between their seat and my seat that means they can't recline. So if you're going to travel long distance and go think about it, think about premium economy. It's expensive. Not as bad as business, but it's expensive, but the seats are wider. There's much more leg room, and they go back to about 35, 40 degrees, depending on the product. Some premium economies are better than others, but it's a good investment if you're going to travel a long distance and expect to be in any kind of decent condition at the far end. Most A350s, A380s and B787s have disabled accessible toilets on board in the middle of the toilet row, in the area between the economy class and the premium economy class. And the disabled access toilet is actually two toilets side by side that have a door that opens between the two. So you can use one toilet area to move a wheelchair or do whatever you need with a second person, and the other toilet to actually do your toileting. And because it's in the middle of the aircraft, even somebody like me, 6'4", can stand up straight, wiggle your arms to get your sleeves back in and so forth. If you're travelling long distance, remember the risk of clots in the legs, and wear stockings, and talk to your doctor about whether they think you should have a little shot of heparin or something on the way. The other thing to remember is that most aircraft are they're all a mountaintop experience, and we know that because we look down and we're looking down from 10 kilometres up. Interesting. Have you ever thought what would happen if you went down from 10 kilometres up? Well, there we go. But the pressure inside most aircraft is set at 2,500 metres above sea level. So that's the height of Mount Cossey, better than Mount Cossey, a bit higher than Mount Cossey. Lower partial pressure of oxygen. So at that cabin pressure, you'll feel washed out, dried out, and a bit dopey quicker than if you go in one of the new aircraft, and the particular ones are the 787 and the 350, where they have the cabin pressure set at 1,700 metres. So, got there in the end. Hello. To summarise, brain tumours, driving and travelling. Thoroughly impartially assess safety for living activities, all living activities, but particularly regard to driving, and I hope I've given you a quick sort of skate through what the thinkings are. The possible outcome of assessing for driving is that a person may not be fit to drive. And if that's the case, it's nothing personal. It's not that you're a horrible person. It's just the results of whatever the treatment you've had and the condition you've got has left you with insufficient ability to safely control a car. And even the lightest of cars weighs half a tonne. It's a lot of metal. So the possible outcomes are not fit to drive or drive with limitations, and the limitations might be 5 kilometre radius, 10 kilometre radius, daylight only, or maybe low limitations. And long distance travel can be possible with appropriate assistance and ongoing follow-up, just like any other chronic disease. Because one of the things that is slowly happening is that brain tumours are becoming more and more like ongoing chronic diseases that people live with. It's not still nearly as good as it will be, but it's certainly nowhere near as bad as it used to be 30 years ago. So it's a chronic disease and it needs follow-up to live with and readapt how you're going at each stage. And I think that's probably it. Thank you. Thanks.
There's a burning question for Andrew because he wasn't part of the panel discussion. We can field it. I'd like everyone to thank Professor Andrew Cole. And the reason for the slightly shorter... Sorry, Michael.
I'd like to ask Andrew, why haven't we got a statewide service for OT assessments of people returning to driving? Because this is something that rehab...
I know, it's a real issue.
Your psychologist won't give you an answer. Your
That's right.
Sit on the fence. Your OT is the only person who does something black and white.
Yep.
And as a clinician, this is a huge issue.
I agree.
This is not a minor issue.
No, it's a huge issue.
Almost more than what private radiotherapy costs.
The answer is local health districts. The answer is local health districts. So certain local health districts do have driver assessment services within their boundaries. So in northern Sydney, we've got the service at Royal Ryde out at Putney. In the St George area, we've got, which is one of the other places I go to, we've got one at Calvary. But they're the only... there was one in the west as well. I don't know whether it's still operating after they did the things they did to Auburn Hospital recently. But essentially, they are services that have been set up by rehab units that see a particular need without separate subsidy from the districts, and that's the problem. Services like, once you get beyond acute care, services that have like a chronic care tail, their funding priority diminishes exponentially the further you get from the acute diagnosis, and unfortunately that's the answer. If there was a statewide driving service in Sydney, I think it would just make it almost impossible to access it. So I think the answer does lie in developing and patronising individual services in individual districts that are accessible within a 15-20 minute travel distance to the people living there.
Those people still charge.